Hi, my name is Zachary Smolar, and for the medicinal chemistry final presentation, I am going to be talking about the use of OnabotulinumtoxinA in the treatment of migraines and medication overuse headache. So what is OnabotulinumtoxinA? It's colloquially known as Botox, which is a protein and a neurotoxin. And as a neurotoxin, it's produced naturally by the Clostridium botulinum bacterium that is in your body. There are 7 varieties of Botox, which are labeled A through G. OnabotulinumtoxinA is the type labeled A. It is a drug that is administered as a series of either intramuscular or intradermal injections, the sites of which are generally the areas from which symptoms originate. It's used in migraine disorder and headaches, excess sweating, overactive bladder, excess salivation. For cosmetic purposes, it's used for wrinkles, and it's also used for cervical dystonia and other muscle spasms. It is an acetylcholine release inhibitor. Acetylcholine contracts smooth muscles, so inhibition of this production will lead to muscle stiffness or paralysis. On the right is an image of what OnabotulinumtoxinA looks like. It is very large. It has a molecular mass of 149 kilograms per mole. And as you can see, it contains many atoms from the chemical formula. So a little bit about how Botox works. It's known to bind to polysialoganglioside, also known as PSG. It contains sialic acid residues, which are the components of glycoproteins. It binds to the synaptic protein vesicle 2, which is this sp2, which is a vesicle protein that is exposed during fusion. So after that, it enters the cell by endocytosis. It then translocates into the cytosol, cleaves the SNAP25, also known as the synaptosomal associated protein, with a weight of 25 kilodaltons. That's where the 25 comes from, which is a component of a complex that allows for membrane fusion specificity, and it brings the synaptic vesicle and the plasma membranes together. Because of this, the synaptic vessels become incapable of fusing with the membrane, as seen here, which prevents the release of the contents in the synaptic vesicles and causes muscle stiffness. So some of the side effects of Botox include injection site redness, bruising, swelling, pain, and infection, dizziness, difficulty swallowing, proper respiratory infections, nausea, headache, muscle weakness, and something called botulism, which is poisoning from the botulinum toxin, which is what you are being injected with, so it makes sense. On the right is a figure of the injection sites for Botox treatment of migraine, which is something that I undergo. It is not a pleasant treatment, but I have found that it works quite well for me. And I'll go into that a little bit more later. So as far as FDA approval and the dosage information for Botox are concerned, it's made by Allergan Incorporated, which is a pharmaceutical company headquartered in Dublin. It was granted FDA approval on December 9th, 1991, BotoxA was. The weird thing about Botox is the dosage is measured in units. So 5 units is 0.1 milliliters of the botulinum toxin. So for migraine injections, you have 31 injection sites across which 155 units are administered, which works out to 3.1 milliliters across 31 sites, or 0.1 milliliters per site. It was approved with a boxed warning because of the toxin. The boxed warning documented the risk of the toxin spreading throughout the body, which could result in botulism, which I talked about on the previous slide. It's a form of poisoning that arises from the production of the toxin. The warning details the effects of the toxin spread, which include difficulty breathing and swallowing, both of which can be life-threatening. And another form of Botox, Botox B, is also approved by the FDA. This was done on December 8th, 2000, and it's used to treat cervical dystonia, a condition in which the neck muscles involuntarily contract. It causes your neck to tilt to one side and get stuck, or to kind of teeter back and forth, almost like nodding uncontrollably. So here's some safety data for Botox as a chronic migraine treatment. All adverse events with 5% or greater prevalence in those with Botox exposure are shown in this table here. As you can see, 71.4% of all people with BotoxA exposure experience some sort of adverse event. The three most common in the people that received Botox treatment were neck pain at 13.8%, muscular weakness at 9.2%, and headache at 8%. While these are the highest for people that receive Botox, only 2.4% of placebo patients experience neck pain, 0.3% muscular weakness, and 5.5% headaches. Among placebo treatments, upper respiratory tract infection and headache were the most common adverse events. The study was a DBPC exposure study, which it says up here, which means it's double-blind and placebo-controlled. It had a mean age, the trial, of 42 years old. 91% of participants were Caucasian and 85% of the participants were female. The selection criteria they used were people 18 to 65 years of age that had more than 15 headache days per a 30-day baseline screening. No prophylactic headache medication 4 weeks prior to the trial, so no preventative treatments, only abortive treatments. No previous exposure to any sort of botulinum toxin serotype, and there were no pregnant people allowed in each trial. So now I'm going to go into a couple clinical reviews, the first of which will be about chronic migraine and the other will be about medication overuse headache. So this is the clinical data for the efficacy in reducing the frequency and severity of migraine headaches. The results were collected after 24 weeks of Botox, which is this leftmost block here. And then the rightmost block was an additional 32-week open label extension phase during which people could continue to take the treatment if they felt it was working. So there were two groups, Preempt 1 and Preempt 2. Preempt stands for Phase 3 Research Evaluating Migraine Prophylaxis Therapy. It's a bit of a mouthful, which is why they decided to go with the abbreviation Preempt. They're both Phase 3 trials. The only differences were the primary and secondary endpoints of the trial. The trials were double-blind and placebo-controlled, much like the safety data. The eligible subjects were men and women aged 18 to 65 with chronic migraine, which they defined as more than or equal to 15 headache days per a 28-day period, with more than half of those being migraines. 31 injections were administered with 5 units per injection and 1 injection per site. And as can be seen in both trials, those who were injected with Botox had a larger pain reduction on headache days per month compared to placebo. They had fewer migraine days per month compared to placebo. And they had less acute headache pain medication intake compared to placebo, especially in Preempt 2. All the p-values were less than or equal to 0.05. It's not listed in the table, but it was listed in the paper for values next to which there are 1, 2, or 3 asterisks, which those values are statistically significant. That's what a p-value below 0.05 means. So they also recorded clinical data for a Compel study, chronic migraine OnabotulinumtoxinA prolonged efficacy open label. It appears as though the people studying Botox were coming up with increasingly labored abbreviations for the names of their studies, because this abbreviation is not self-explanatory in the least, but I digress. So there were 3 12-week cycles of treatment that were studied, aptly named cycle 1, 2, and 3. The eligibility criteria for this study were the same as those from the Preempt studies. So nothing changed in terms of the kinds of volunteers or patients that were going to be studied. Between the first and second cycles, there were substantial reductions in headache days per month, about 688 to 349 percentage. For moderate to severe headache days per month, a similar trend, and same with cumulative hours of headaches on headache days per month, and this HIT-6, which is a headache impact test. It's designed to measure how much of an effect headaches have on one's ability to function in everyday life. There appeared to be a bit of a diminishing return upon the third treatment cycle. The headache days per month actually increased slightly from 249 to 271. This is a typo in the paper, in the figure actually. But the presence of severe headaches, cumulative hours of headaches, and the HIT-6 scores still decreased further between cycles 2 and 3. So there may be an increase in headache days per month slightly, but the severity, the length, and the effect on your everyday life still did decrease between cycles 2 and 3. Next, we're going to go into the clinical review on medication overuse headache, which is a pretty self-explanatory term. It comes from a person being too reliant on analgesics for headache treatment, such as Tylenol or ibuprofen, and going through withdrawal every day because their body needs the medicine to fight off the headache. So these are results of a double-blind randomized placebo-controlled study. Those given Botox consumed fewer analgesics than those given the placebo on average. So that's this mean acute pain drug consumption. As you can see, all these values are lower than the placebo values. The study had a 4-week baseline screening phase, followed by a 12-week double-blind parallel group placebo-controlled phase with 1 injection cycle at day 0 of the double-blind phase, followed by 12-week open label phase. Participants were selected from patients that were waitlisted for outpatient headache consultations. So they were waiting to see a doctor about alternative treatments, and they were taken off of that list. Patients were to keep a daily headache diary to record symptoms, treatments, starting 2 months prior to the baseline period. So the clinicians knew ahead of time what kinds of headaches they were dealing with and how they were treating them. Patients had to be within the age range of 18 to 65 again, have a history of headache with greater than or equal to 15 headache days for 28 days over the previous 3 months. So while the results do show a correlation between taking Botox and a rejection in both headache days and acute drug consumption, as can be seen here and here, the p-values were quite large, except for the mean acute pain drug consumption for 28 days after 12 weeks. So while the results do show a correlation, the data isn't really statistically significant, except for that one value. Oh, sorry. This is a graph of the points on the previous slide. So on the left is the headache days for 28 days, and on the right is the days with acute headache medication consumption for 28 days. It's just kind of an illustration of what was shown before. On the left side, the only statistically significant value again is the Botox after 12 weeks. The reduction in headache days had a p-value below 0.05. And on the right side with the acute headache medication consumption, the only statistically significant value was that after 12 weeks, a p-value of 0.015, Botox patients had less acute headache medication intake than those that received placebo. On a personal note, I have suffered with migraines and subsequently medication overuse headache for most of my life. I have undergone a lot of treatments. None of them really worked until I started Botox, and it wasn't a pleasant procedure, but I figured I'm having pain every day. I should try something that may be painful in the short run, but be beneficial in the long run. And it really has worked wonders. So that's why I wanted to talk about Botox. I wanted to, describe the toxin aspect, which I found to be very strange. And I also wanted to describe the results of the clinical studies, because I have seen positive effects and I know others have as well. So thank you for listening to my presentation. These are my references that I drew information from. I'd be happy to answer any questions that you may have, either with regard to the presentations or my personal experience with Botox. Thanks again.